with this outline: the anatomy, definition, epidemiology, etiology, clinical presentation, investigations, diagnosis, differential diagnosis, management to treatment, prognosis, then principal complications. So the anatomy, the pericardium serves as a protective barrier from the spread of infection or inflammation from adjacent structures. It is composed of the parietal pericardium and the visceral pericardium. The pericardium normally contains as much as 20 to 50 mL of an ultrafiltrate of plasma. The acute pericarditis refers to inflammation of the pericardial sac. The term myopericarditis or perimyocarditis is used for cases of acute pericarditis that also demonstrate features consistent with myocardial inflammation. So acute pericarditis is inflammation of the pericardium that either occurs as an isolated process or with concurrent myocarditis. Then constrictive pericarditis is characterized by compromised cardiac function caused by a thickened, rigid, and fibrous pericardium secondary to acute pericarditis. Now, epidemiology. Acute pericarditis is the most common disorder involving the pericardium. The exact incidence and prevalence of acute pericarditis are unknown. However, acute pericarditis is recorded in approximately 0.1 to 0.2% of hospitalized patients and 5% of patients admitted to the emergency department for non-ischemic chest pain. It is more common in men than in women. It does not spare age, but adolescents are more commonly affected than young. Several clinical settings where it may be either the first manifestation of an underlying systemic disease or represent an isolated process. In developed countries, most cases of acute pericarditis are considered of possible or confirmed viral origin, although the exact etiology of most cases remain undetermined following a traditional diagnosis approach. Patients with HIV infection treated with antiretroviral therapy who develop acute pericarditis have an etiologic spectrum very similar to non-HIV infected patients. However, HIV infection itself, along with tuberculosis, persists as major causes of acute pericarditis in developing countries or in patients with access to antiretroviral therapy. Malignant disease is the most common cause of cardiac effusion with tamponade in developed countries. However, tuberculosis should be considered in endemic areas. So the etiology, the most common causes, we have the infectious and the idiopathic. And the infectious, we have the viral being the most common. Then we have the bacterial causes, fungal, and the toxoplasmosis. And pericarditis can also be caused following an MI, which we call the post-infarction fibrinous pericarditis. And it can also present itself in Dressler syndrome, which is caused by the immune system response to the heart damage. Then we also have pericarditis occurring after pericardiotomy, which we call the post-pericardiotomy syndrome. And in also some systemic diseases like the systemic lupus erythematosus and then the rheumatoid arthritis. Then the other causes, we have the renal failure. In this one, we mostly talk about the uremic pericarditis. We have the tumor radiations, and we should know that tuberculosis is the most common cause of constrictive pericarditis in developing countries. So acute pericarditis can present with a variety of non-specific signs and symptoms depending on the underlying etiology. The major clinical manifestations of acute pericarditis include chest pain, which is typically sharp and pleuritic, steady, radiating to back, neck, or jaw, and improved by sitting up and leaning forward. Then pericardial friction rub, which is a superficial, scratchy, or squeaking sound, best heard with the diaphragm of the stethoscope over the left sternal border. Then the ECG changes there will be a new widespread ST elevation and PR depression. There can also be atypical ECG changes in some cases that simulate ECG changes seen in the patient with acute coronary syndrome. Then the pericardial effusion. The pericardial effusion is a common feature of pericarditis, but it's not required for diagnosis. So patients with an infectious etiology may present with signs and symptoms of systemic infections such as fever and leukocytosis. The viral etiology in particular may be preceded by flu-like respiratory or gastrointestinal symptoms. Patients with a known autoimmune disorder or malignancy may present with signs and symptoms specific to their underlying disorder. So the investigation. Usually the investigations, we do it to help in the diagnosis and to also rule out some other conditions and even diagnose complications. So we usually start with the FBC, which is the full blood count. And in this, when we do it, it will guide us to know whether it is towards a viral, or that is when the lymphs are high, or towards a bacterial infection when the leukocytes are high. And the ESR, that's the erythrosedimentation rate, which usually is high in acute pericarditis, and the troponin is also high in acute pericarditis, and then the C-reactive protein, which in about 78% of the cases is usually high. Then the blood urea and creatinine. This one, we usually use it to find out. There are cases of uremic pericarditis. So if we don't know whether the person is in acute kidney failure or chronic kidney failure, if we don't do this one, usually you are not able to determine the cause of the pericarditis. Then the ECG, you have a diffuse ST segment elevation or T-wave inversion. Then PR segment depression, low voltage waveform. Then electrical alternance, which is the narrowing, which is the electrical alternance is the alternating QRS amplitude that is seen in any or all leads on an ECG with no additional changes to the conduction pathway of the heart, usually associated with pericardial effusion. The chest X-ray in acute pericarditis is usually unhelpful, except in complicated ones that you are thinking of either effusion or tamponade. Then echocardiogram, as I said, usually in effusion. So the diagnosis of acute pericarditis takes in the form of you have to find the history, the physical examination, and the ECG changes. So in the history, you consider disorders that are known to involve the pericardium, such as prior malignancy, autoimmune disorder, uremia, recent myocardial infarction, and prior cardiac surgery. And then the physical examination, usually pay attention to the auscultation for a pericardial friction rub and the signs associated with cardiac tamponade. And in the ECG, we find a new widespread ST segment elevation. So the differential diagnosis. These differential diagnoses are those conditions that simulate acute pericarditis. And there are a lot of differential diagnoses, but I will just make mention of a few among those that are seen on the screen. So we have the acute gastritis, which is one of the most common differentials or presentation in our emergency, which is the inflammation of the stomach lining with signs and symptoms of dyspepsia. And there's mostly epigastric tenderness. Then we also have the angina pectoris, which is usually a chest pain due to coronary heart disease. The pain here is squeezing, pressure, heaviness, and tightness in the chest. Then we have the aortic dissection, which is usually a medical emergency with sudden severe chest pain, and then it is in the upper back pain that also radiates to the neck or down the back with loss of consciousness and shortness of breath. Then we have the aortic stenosis, which is the narrowing of the aortic valve opening, making the heart work harder, causing chest pain, fatigue, and shortness of breath. So I'll go to esophagitis. So which is the inflammation that may damage tissues of the esophagus, causing painful, difficult swallowing and chest pain. Then we have gastroesophageal reflux disease, that's a GERD, which is a condition in which the stomach content leak backward from the stomach into the esophagus. It usually presents with burning chest pain, which mostly occurs after eating and worsens when lying down. They have the myocardial infarction. Well, this one at the end of the presentation, there's a clear difference at the end. That is comparing myocardial infarction and then that of the acute pericarditis. So we'll move on to the peptic ulcer disease, which is also a condition in which painful sores or ulcers develop in the lining of the stomach or duodenum with signs and symptoms of dyspepsia. Then the pulmonary embolism, which is a blockage in one of the pulmonary arteries in the lungs, in most cases due to blood clot that travel to the lungs from DVT, causing cough, chest pain, and shortness of breath. Let's move on. So treatment in acute pericarditis. The goal of therapy are to relieve of pain, resolution of inflammation, and the prevention of what? Recurrence. So most low-risk patients with acute pericarditis can be managed effectively in an ambulatory setting, while high-risk patients should be admitted to initiate therapy or treatment and continue the diagnostic evaluation. Patients should be instructed to restrict strenuous physical activity until symptoms have resolved and biomarkers have normalized. For nearly all patients with acute idiopathic and or viral pericarditis, a combined therapy with colchicine plus NSAIDs is recommended. For patients with an identified cause other than viral infection, specific therapy appropriate to the underlying disorder is indicated. Glucocorticosteroid should be used for initial treatment of acute pericarditis only in patients with contraindications to NSAID, example in renal failure or pregnancy at more than or equal to 20 weeks gestation, or for specific indications such as systemic inflammatory diseases, and should be used at the lowest effective dose. Then during treatment, we have something we call the tapering treatment. Following the resolution of symptoms, we taper the dose of the anti-inflammatory agents weekly for several weeks in an attempt to reduce the subsequent recurrent rate. Colchicine is continued for a total duration of 3 months. If you read the case scenario, that was exactly what was said there. Refractory or recurrent symptoms, most patients whose symptoms worsen or recur following the initial course of therapy can still be managed effectively with medical therapy alone, and outpatient management remains feasible in almost all cases. High-risk patients with acute pericarditis should be admitted in order to initiate appropriate therapy and expedite a thorough initial evaluation. And then the high-risk features include fever of more than 38 degrees Celsius, subacute course, that is without acute onset of chest pain, evidence suggesting cardiac tamponade, that's hemodynamic compromise, a large pericardial effusion, that is an end diastolic echo-free space of more than 20 millimeters, immunosuppression and immunodepressed patient, anticoagulant use, example vitamin K antagonist, example warfarin, or novel oral anticoagulant. Acute trauma, failure to show clinical improvement following 7 days of appropriate dose NSAID and colchicine therapy. Elevated cardiac troponin, which suggests myopericarditis or perimyocarditis. Patients with none of these high-risk features can be safely treated on an outpatient basis. Then the medical therapies. So we have the non-steroidal anti-inflammatory drugs, that's the NSAID. For nearly all patients with acute idiopathic or viral pericarditis, NSAIDs are recommended in combination with colchicine as the initial treatment. Failure to respond to aspirin or NSAIDs therapy within 1 week suggests that a cause other than idiopathic or viral pericarditis is present. In such instances, a thorough search for the etiology should be performed. Primary therapy has been the administration of oral NSAIDs, particularly ibuprofen or aspirin. Ketorolac, which is a parenteral NSAID, is also effective. NSAIDs, including aspirin, function to both reduce inflammation and relieve pain in most patients. Duration of treatment is based upon the resolution of symptoms and normalization of C-reactive protein. In this approach, C-reactive protein is assessed at presentation and then weekly using the NSAIDs, the dose of NSAIDs until complete resolution of symptoms for at least 24 hours and normalization of C-reactive protein, at which point tapering begins. In symptomatic pericarditis occurring within days after an acute myocardial infarction, aspirin plus colchicine is recommended rather than another NSAID plus colchicine. So this is the NSAID dosing. So you can use ibuprofen 600 to 800 milligrams 3 times per day, and the aspirin you can use 650 to 1,000 milligrams thrice per day. The indomethacin 25 to 50 milligrams thrice per day. However, indomethacin is associated with more side effects, and it is usually considered for recurrence. Following the resolution of symptoms, we taper any of these doses weekly for 2 to 4 weeks in an attempt to reduce the subsequent recurrence rate. So patients with high dose or prolonged period of treatment with NSAIDs, history of peptic ulcer disease, age greater than 65, and concurrent use of aspirin, corticosteroid, and anticoagulant, we have to be careful with them because they are at high rates of gastrointestinal toxicity, example, gastritis, ulcer, and such patients should receive concomitant gastroprotective therapy with proton pump inhibitors, which example are the omeprazole and the pantoprazole. These two are generally preferred due to their efficacy and favorable safety profile. So colchicine. For all patients with acute idiopathic or viral pericarditis, we recommend that colchicine be added to anti-inflammatory therapy. Colchicine, when used as an adjunct to NSAID therapy, reduces symptoms, decreases the rate of recurrent pericarditis, and is generally well tolerated. However, for patients with diagnosed bacterial pericarditis, colchicine has not been proven efficacious and, on the contrary, may theoretically impair the clearance of the infectious agent. Colchicine is also not proven to be efficacious in malignancy-related pericarditis. So the dosage, that is colchicine doses. So colchicine may be given with or without a loading dose. When a loading dose is chosen, the loading dose is typically 0.5 to 1 milligram twice daily on day 1. The daily maintenance dose of colchicine is a weight base. So if patient weigh more than or equal to 70 kg, they should receive 0.5 to 0.6 milligram twice daily. And if the patient is weighing less than 70 kg, should receive 0.5 to 0.6 once as a daily dose. Then the glucocorticoid dosing. Patients who require glucocorticoid therapy for acute pericarditis, a use of moderate initial dosing is recommended, example 0.2 to 0.5 milligram per kg per day of penicillin, followed by a slow taper rather than high dose with a rapid taper. A proposed tapering scheme follows. Daily dose of more than 50 milligram. The tapering should be 10 milligram daily every 1 to 2 weeks. If the daily dose is 25 to 50 milligram, the tapering should be 5 to 10 milligram per day every 1 to 2 weeks. And if the daily dose is 15 to 25, the tapering should be 2.5 milligram per day every 2 to 4 weeks. And if the daily dose is less than 50 milligram, the tapering should be 1.25 to 2.5 milligram per day every 2 to 6 weeks. So we also have the adjunct therapies. Most patients with uncomplicated low risk acute pericarditis are managed effectively with medical therapy alone. However, patients may occasionally require adjunctive therapy. Example, in patients with persistent symptoms and elevated heart rate, that's heart rate of more than 75 beats per minute, despite full anti-inflammatory therapies, adjunctive use of beta blockers, if not contraindicated, can be helpful to improve symptoms control by reducing heart rate and the exacerbation of chest pain at high rate. A moderate to large pericardial effusion, particularly if hemodynamically significant and causing cardiac tamponade or symptomatic and refractory to medical therapy, they also need an adjunct therapy. Suspicion of a neoplasm or bacterial etiology and moderate to large pericardial effusion, frequent, highly symptomatic recurrent of acute pericarditis with pericardial effusion, and the evidence of constrictive pericarditis, and then pericarditis and renal failure, this patient all will need an adjunct therapy. So most of the adjunct therapy is surgically related, and these are some of the surgical procedures that are performed to help such patients. There's what we call the pericardiectomy, which is a surgical removal of all or part of the pericardium. Then we have the pericardiocentesis, which is a needle is used to remove pericardial fluid from the pericardial sac. Then we have the pericardial window placement, where an uninflated balloon is passed inside the pericardial space, where it is opacified, inflated, and then pulled through the pericardium to create a window through which pericardial fluid drains into the peritoneum or pleural space. Then we have the subxiphoid pericardiotomy. It creates a pericardial direct communication, allowing for drainage of fluid into the pleural space. Then the complication, we have the constrictive pericarditis and then the cardiac tamponade. If pericarditis lasts more than 6 to 12 months, then it becomes chronic pericarditis. Then we move to constrictive pericarditis, which occurs as a complication of acute pericarditis and is characterized by thickening and rigidity of the pericardium, resulting in both backward and forward failure. So the pathophysiology of constrictive pericarditis. Now, pericarditis may deposit fibrin, which can invoke a pericardiac effusion. This leads to chronic fibrotic scarring and calcification of the pericardium. The pericardial lining becomes inflamed, thickened, and fused. The potential space between the lining is obliterated and the ventricle loses distensibility. Venous return to the heart becomes limited. Ventricular filling is reduced, therefore reduced preload. Filling pressure of the heart tends to become equal in both the ventricles and the atria. Since the myocardium is unaffected, early ventricular filling during the first third of diastole is unimpeded. After early diastole, the stiff pericardium affects flow and the hemodynamics. The dip and plateau waveform or square root sign. The systolic function is really affected until late in the sign of the course of the disease, unlike in restrictive cardiomyopathy. The clinical features, the signs and symptoms of fluid overload. That's right heart failure. There's a jugular vein distension raised, which is evident by the raised JVP. Then Kussmaul sign, the hepatic vein congestion, peripheral edema or anasaka, ascites with abdominal discomfort. Then signs and symptoms of reduced cardiac output, the fatigue worsening by physical exertion, tachycardia, pericardiac knock, and then pulsus paradoxus. So the investigation. So the initial best investigation is the chest X-ray. We can also do the CT and the MRI, the echo, ECG, the cardiac catheterization, where we will see the square root sign. Then the treatment. In this one, you usually search for the underlying cause and then you treat it. And then you also do symptomatic therapy. We manage the fluid overload with diuretics and we do the pericardiectomy. Now, in this slide, we can see there's a comparison to see the difference between pericarditis and myocardial infarction. So the first one is the pain description. In pericarditis, the pain is sharp, pleuritic, retrosternal, which is under the sternum, or left pericardium, which is the left chest pain. Then, but in the myocardial infarction, it's a crushing, pressure-like heavy pain described as elephant on the chest. Then the radiation. In pericarditis, the pain, it radiates to the trapezoid ridge, that's to the lowest portion of the scapula on the back, or it does not radiate. And in myocardial infarction, the pain radiates to the jaw or left arm, or it does not also radiate. Then exertion. In pericarditis does not change the pain. Exertion does not change the pain, but in myocardial infarction, it can increase the pain. The positioning in pericarditis, positioning or upon inspiration, breathing in, the pain is to worsen, that's in spine position. But in myocardial infarction, it is not positional. Onset or duration. In pericarditis, it's a sudden pain that lasts for hours or sometimes days before a patient comes to the ER. But in myocardial infarction, a sudden or chronically worsening pain that can come and go in paroxysms, or it can last for hours before the patient decides to come to the ER. There are other differential diagnoses that we have to think about when a patient comes with chest pain. So when a patient comes with a chest pain, we need to think about it. Is it after an accident or it's not? If it's not after an accident, then we have to think about a lot of differential diagnosis, because after an accident, you might know it's just maybe acute pain due to trauma or some osteochondritis or any other thing. But now, if it is non-traumatic, then we have to look at these differentials. Then I kept them here. We have the heart differentials from the heart, the lung, the esophagus, the aorta, the upper abdomen, the chest wall. Now, looking at the heart side, we have to think about the acute coronary syndrome, the myocarditis, valvular diseases, especially in aortic stenosis, which were earlier on mentioned, and then the lung diseases such as pneumonia, other infections, pneumothorax, pulmonary embolism, and then the COPD. Then in the esophagus, we can think of esophagitis, the gait, spasms, foreign body, rupture. Then in the aorta, we can think of the dissection, aneurysm, and aortitis. Then in the upper abdomen, we can also think about cholecystitis, pancreatitis, ulcer, hepatic disease. Then the chest wall, we can talk about the costochondritis, contusion, rib fracture, then the muscle strain or tear. That's mostly in the accidented patients. So the prognosis in acute pericarditis. The prognosis in acute pericarditis depends on the etiology, the presence of pericardial effusion, and or tamponade. Idiopathic and viral etiologies usually have a self-limited cause without any risk of evolution towards constrictive pericarditis. Most post-myocardial infarction cases have a benign cause. However, pericarditis is associated with larger infarcts, and therefore overall long-term mortality may be increased. Poor prognostic factors at presentation: temperature above 38, presence of a large pericardial effusion or tamponade, unsuccessful therapy with aspirin or non-steroidal anti-inflammatory agent after at least 1 week of treatment. So the references are Davidson Principle and of Medicine 2022 or 22nd edition, Medscape and UpToDate. And then if we move down, we'll see some ECG that we can go and watch. I think that's the end of my presentation.
Okay, great. So we are seeing an ECG. Can you comment on that? Let's go to the first versus second ECGs. Dr. Bagbin, take us through. What's the difference?
So the first one, we can see the ST elevations in almost all the leads. And then in some of them, there's also there's depression of the P wave, and there's also the T wave elevation.
Then the next ECG.
The next is the P wave is depressed, and then the ST segment is elevated. in the 1, 2, V2, V3, V4, V6, V3.
Okay, so what's the difference between the two, like those two ECGs? I thought you brought them like into paint a certain picture. Is that not so? That's just what I'm asking to clarify so that then we can listen. Oh, you don't get my point.
No, boss.
Why did you bring the two ECGs? Are you comparing one to the other?
Yes, so the first one is just the acute pericarditis.
Yes.
And then the second one is the acute MI.
Yeah, so that's what I just wanted to, so that people will get to know. So your first ECG is showing a diffuse saddle ST elevation with PR depressions. The second ECG, this is diffuse. The first one is diffuse, it's all over. The second ECG, like you are seeing on the screen, the ST elevations, number one, are not widespread. They are not throughout all the leads. They are looking at a certain part of the heart that is undergoing ischemia with some reciprocal changes. So one is goes in for the acute pericarditis. That's the first ECG. This one, what is being projected up here. And then the second one goes for an ST elevation myocardial infarction. Okay, so thank you very much, Dr. Bagbin, for a good presentation. We open the floor now for questions. If you have any that you want to type in the chat box, please do. I've just in the comment there. Otherwise, you could raise up your hand electronically and then I will unmute you to talk. Have any comments to make? You could use either the chat box to type this in, or you could electronically raise up your hand. I would unmute you to go ahead and then ask your question so that then we can have a discussion around it. I don't see any hands up. In the chat box, I only see a comment there from Kelvin. Nice presentation, Dr. Bagbin. Thank you, Kelvin. Any questions? Okay, so whilst we wait for that, just to highlight the important part that acute pericarditis is a common thing that we see at the ER. Unfortunately, a couple of times we miss the pericarditis. Commonly here, what I realize is that a lot of people will diagnose you of gastritis or of peptic ulcer disease once you describe a certain kind of chest pain. So it is worth it that we should always look at the nature of the pain. And as well, like you said, even in the midst of everything, ideally, once it's a chest pain or an epigastric pain, usually the list we ask for is that you should do an ECG. There may just be more to it. I want to highlight the fact that even somebody who has trauma, unlike Dr. Bagbin trying to rule out issues, medical issues, anybody who has trauma, we don't just ascribe it to either musculoskeletal pain, costochondritis, or blunt abdominal trauma. Today, we discussed a case where somebody had a blunt abdominal trauma, and when he came in, the ECG was significant for an anterolateral ST elevation myocardial infarction, which is a medical, which is significant for, and it was an anterolateral ST elevation myocardial infarction, which is a medical emergency. So obviously, we'll say that even in the midst of trauma, the trauma could just be a red herring. What will kill you would have been that acute coronary syndrome, would have been that STEMI if it wasn't tackled and looked at. So it's something to be aware of. There's a question in there. I want to find out about alcohol consumption connection with pericarditis. Most of the scenarios, they say following bowels of alcohol consumption. Dr. Bagbin, do you have a response to that? Let me try unmuting. Dr. Bagbin, so you can unmute yourself and then see if you want to attempt that. Alcohol consumption with acute pericarditis, any relationship that you saw in your reading?
Yes, boss. People who usually drink alcohol are usually related, they have heart-related diseases, actually. So I don't really have much details in connecting to the pericarditis, but that is what I can actually say. With relation to the agent, it can lead to heart diseases.
Okay, so alcohol goes more for acute pancreatitis rather than pericarditis, but the more thing that alcohol could probably lead to is by way of increasing your risk of pericarditis is via the pathway of hypercholesterolemia and forming adhesions on your pericardial surface, and thus leading to pericarditis. Also, again, usually pericardial effusion as a complication of the pericarditis in the setting of acute pericarditis is something that then we have to be aware of. And of course, anything that increases your cardiac inflammation, including alcohol, including smoking or any of that, can, of course, predispose you to having pericarditis. But like the commonest, like he mentioned, is usually the viral etiology. Great. Imad does say a nice presentation. Viral pericarditis with superimposed renal failure. Do you still go for the steroids? Dr. Bagbin, do you want to take that? Steroids in the presence of, I think, pericarditis from uremia, so uremic pericarditis.
So, boss, I think you can help me with that.
So uremic pericarditis, obviously, like you said, when we are managing pericarditis, we do not look at just the pain relief or any of that. We are looking at the underlying cause. So if you have a uremic pericarditis, obviously you got to reduce the urea levels. In the acute setting, we start you on a PPI. Back before the impurities that were found in the, what's the name of that medicine? Other than before, we're using the PPIs, the omeprazole and all of that. There was the ranitidine, fantastic. So we used ranitidine in the past, but obviously there were some impurities worldwide that was found. So most people have moved more towards the use of the PPI in that setting. But obviously the right thing to do is to sort out the cause of that uremic pericarditis and reduce the urea levels either through dialysis or the urea chelating drugs. Great. I don't see any questions in the chat box. Again, as well, I don't see any hands up. So just to thank you all for joining us for today. We'll be able to do this under 1 hour. Next week, we'll be looking at another topic. It will be advertised on the various platforms like always. So till next week, please take good care of yourselves. Thank you very much. I just see 2 comments that have come up. Great presentation, more of such be organized. Okay, thank you. And then great. All right. So thanks guys for joining us. Bye-bye. And thank you, Bagbin, for a good presentation.